off with MKSAP rheumatology, and we will be hearing from the session by Dr. Scott Young, Namrata Singh, and Gregory Gardner. So we have two rheumatology experts and then a hospitalist, and I really appreciate all the work they did to put this together. So we'll go through a couple questions and then talk about all the answers together. All right.
Okay, great. Yeah. No, thank you very much. Are we all here? Are we ready to go?
Yeah, we can go ahead and start.
Perfect. Yeah. So hello, everyone. I'm Scott Young. I still call myself one of the new hospitalists at University of Washington Medical Center, Montlake, just because it's been still less than a year. But so I've met maybe a few of the residents, but not as much as I would like. But and yeah, so just have some MKSAP questions. It's from the 2018 Q Bank is what I have. But so yeah, without further ado, we'll go ahead. I have no conflicts of interest. I don't MKSAP or anything otherwise. So this is just a picture of the San Juan Islands, specifically San Juan Island. I went there, so just it's beautiful right now. It was a great day. But okay, and then yeah, so first, this is just the first question, and I like to, for MKSAP questions, I usually like to read the kind of the question stem first. Is there someone that can read this for me? Who would like to? If not, I can. But...
We can't see the question stem. We only see the question.
Oh, sorry. I meant, sorry, the question. Yeah, you're right. I think I said question stem, but I meant just the question.
So which of the following is the most likely diagnosis? Chikungunya infection, disseminated gonococcal infection, reactive arthritis, or sarcoidosis?
Okay, great. Thank you very much. And then with that in mind, here is the prompt, the actual question. And can someone read this for me?
Yeah, I can read it. Can you guys hear me?
Thanks. Yeah.
A 26-year-old woman is evaluated in the emergency department for an acute onset of fatigue, chills, and joint pain in the fingers of the left hand, left wrist, and right ankle during the past 3 days. There is no travel history. She is currently taking ibuprofen for her symptoms. She also takes an oral contraceptive pill. On physical exam, temp is 39, blood pressure 114/72, and pulse 106. Fusiform enlargement of the second and fourth digits of the left hand with pain on extension is noted. Tenosynovitis of the dorsum of the left wrist and right ankle is present. Painless lesion on the palm is shown.
Okay, yeah, thank you. So we'll just give you a second just to look at that real quick, and I'll show you the lesion here is on the next slide. Let's see if I can, there we go. Everyone can see that. And then give you a second to look at that. Okay. And then now, does anyone, now we're gonna vote, just kind of vote what you think is the answer. Does anyone though need me to go back to the question prompt or a little more time on that, or take another look at the picture? Okay, great. Well, then we can vote now.
All right, I'll just give everyone a couple more seconds to get any last minute votes in.
Okay, great. So yeah, I see the poll results. So good. Yeah, no, I think we had a good spread. I think no one mentioned chikungunya or sarcoidosis, which I think is good. The question stem didn't give anything about chikungunya. It can have fevers and such and kind of myalgias, but there was nothing about, it's very, very rare in the United States. It's almost exclusively from people coming in. So unless if they give you a travel history and such. So yeah, that's good not to put that. And then also sarcoidosis. Yeah, I agree. Yeah, this sarcoidosis, of course, can kind of present in a myriad of ways, but this is not really one of them or consistent with that. So yeah, I think most people were between B or C, which I think are both really good thoughts. Definitely reactive arthritis can, after an infection or such, people can have certain symptoms of arthritis, kind of like this. I think that the correct answer is B, so good job. Lots of you got that correct. And let's see, 72 and 28, that's basically, let's see if I can go to my next slide. That's pretty close with the MKSAP. Is that, oh yeah, the main key here, I think, is that this kind of vesiculopustule, that can be, kind of a sign of disseminated gonococcal infection. So here too is kind of the answer, just taken directly from MKSAP. So can I have someone volunteer to read this?
Yeah, I can read it.
Great.
So answer choice B, the most likely diagnosis is disseminated gonococcal infection. Patient has arthritis dermatitis syndrome of DGI due to Neisseria gonorrhea. Syndrome is characterized by a triad of tenosynovitis, dermatitis, usually painless pustular or vesiculopustular lesions, and polyarthralgia without frank arthritis. Fever, chills, and malaise are common. Inflammation of multiple tendons of the wrists, fingers, ankles, and toes distinguishes this syndrome from other forms of infectious arthritis. Presentation is associated with positive blood cultures and characteristic skin lesions. Diagnosis is established by blood and synovial fluid cultures, as well as pharyngeal, cervical, urethral, and rectal cultures, and/or nucleic acid amplification testing. Testing patients and their partners for both gonorrhea and chlamydia is critical. Initial therapies, usually with ceftriaxone plus either azithro or doxine, is rapidly effective.
Yeah, great, thank you. And yeah, and remember the ceftriaxone can be intramuscular. So you see this too. I specifically selected kind of hospitalist type questions, but you also definitely can see this in clinic as well. And then this is the second part of the answer sheet. I won't belabor it too much, but especially since it talks about, you can read it by yourself if you like, or come back to these slides. But the chikungunya virus, as I said, isn't usually in US. Sarcoid down at the bottom doesn't usually present this way. And then the reactive arthritis, kind of this middle paragraph, is kind of interesting. I can just read that. Reactive arthritis, an acute asymmetric arthritis that typically follows chlamydial urethritis or infectious gastroenteritis within 6 weeks. It mainly affects the lower extremity joints. Remember, our person had some upper extremity, but enthesitis, particularly at the Achilles tendon, can also occur. Can also have conjunctivitis, circinate ballantitis, or keratoderma blennoragicum, which is a unique kind of skin finding. And a pustular or vesiculopustular rash is not part of the reactive arthritis syndrome. So I think just my key takeaways are, with the pustule, think gonococcal infection, no pustule or other signs, maybe more reactive arthritis. And then remembering that triad, that kind of arthralgias without frank arthritis could be or the tenosynovitis could be kind of tips. With that, I don't want to hog it. I just want to say, for that question, for our rheumatologist with us, if they have any other input or things to add to that.
Can you hear me okay?
Yes.
So when I was a resident back in the 1980s, gonococcal arthritis is felt to be the most common cause of septic arthritis, which it no longer is. In fact, I wonder how many people have actually seen a case of gonococcal arthritis among the group. Not very common anymore. One other interesting point is the arthritogenic strains typically do not cause GU symptoms. So that's another little pearl to remember. And also the other point that you made, if you want to make a diagnosis, you really have to swab everything, because it's very hard to make a diagnosis otherwise. Namrata, any thoughts?
Yeah, no, agreed. I don't think I've suspected, of course, a lot of times DGI, but I don't think ended up, maybe once in fellowship had diagnosed DGI. And then for sarcoidosis, I think something to keep in mind, I would say, is the a lot more than the typical triad of Lofgren, where, the hilar adenopathy, erythema nodosum, ankle pain. Actually, I've seen more incomplete Lofgren. I don't know if you differ, Gigi. I think I've seen where maybe they have 2 of the 3, not all 3. And there's a term called incomplete Lofgren that sometimes I put them under and monitor them to see if they evolve into like, and treat them like if it was Lofgren. So that's the one other thing I would say, that rather than a very typical triad, sometimes patients, present with a little bit incomplete presentation. Reactive arthritis we talked about. Yeah, so yeah, questions perhaps if anybody has that made them choose the 28% that chose the other option. Please let us know if there was something still confusing. I guess we can then go on to the next one.
Yeah, I think we can go on unless there's any other questions. So this is just another picture really quick. I don't know what these caterpillars are, but this was just now, and it's kind of gross, but also very interesting, cool. So it's also in San Juan. So and then can someone read the question and the answer choices for me, please?
I can read it. Which of the following is the most likely diagnosis? Germ cell tumor, IgG4 associated retroperitoneal fibrosis, lymphoma, or malignant peritoneal mesothelioma?
Great, thank you. And then here is the question. And can I have another person volunteer to read this? Okay, I can read it too. I'll take this one. So 55-year-old man is evaluated in the emergency department for a 1-month history of low back pain and lower extremity swelling during the past 2 weeks. If history is significant for a goiter that was surgically removed 5 years ago, pathology revealed extensive fibrosis. He takes levothyroxine. On physical exam, temp is normal, blood pressure 165/90, pulse 88, respiration 18, surgical scar of the anterior neck, 2+ lower extremity edema to the mid-calf bilaterally. The rest of the exam is normal. We have a hematocrit of 34, a creatinine of 2.1, and a normal UA. Abdominal ultrasound shows bilateral hydronephrosis. Non-contrast CT of the abdomen and pelvis shows a soft tissue mass surrounding the infrarenal aorta without any significant lymphadenopathy. The ureters are encased within the mass. So I have to give everyone just 1 second to look at that real quick. And then back to the questions. And then, yeah, if we're all ready, does anyone need more time back at the questions, or otherwise we can vote?
Yeah, you can just leave the stem up while we're voting if you want. That way
Oh,
people
great.
can refer to it and they can see the answer choices on the poll.
Oh, perfect. That's even better. Great.
The 1 minute Zoom.
Yeah, give you a minute to vote.
All right, send in your final votes.
Okay, great. Awesome. You guys are doing fabulous. So yes, I would say we don't need to spend, I guess, too much time. I guess many of you got it right, but yeah, that is the correct answer. It is retroperitoneal fibrosis. But I did see, a good, 15% or so of folks who are thinking maybe something else. A lot of these, there's either lymphomas or cancers, certain type. I would say for malignant peritoneal mesothelioma, usually doesn't kind of have like a retroperitoneal mass. Usually isn't a presentation. It can metastasize from the pleura, but for lymphoma, that is, since this CT didn't show any significant lymphadenopathy, sometimes, especially on a non-contrast CT, sometimes, maybe that can be hard to tell. It should still show it on a non-contrast, but I think that kind of makes it less likely. And amongst also too, it doesn't really explain the pretty interesting or pretty unique finding of, a fibrotic thyroid previously. And germ cell tumor kind of similar, in males can have a germ cell tumor, and that we kind of think of the cannonball chest x-ray with the metastases often do go kind of along the midline, either in the chest or sometimes in the peritoneum or retroperitoneum. But then given that, it doesn't quite explain the imaging findings in the fibrosis. So, but good job. That was great. I just, and that's what this, you guys did a lot of people to get this one as well. So, so this, I think this part is worth reading. If we could have someone read this explanation, that'd be great.
Scott, this is John Cho, one of the faculty members. Could I suggest that, just so that we can get through a lot of things, that we summarize some of the readings? The residents will get these slides later.
Oh, for sure. Yeah, no, great. I think that's a great recommendation. So yeah, I think basically to summarize this, that, this is kind of actually a classic presentation of retroperitoneal fibrosis. Someone coming in with back pain and a bit of an AKI, as they do often have obstructive uropathy, like seen on a renal ultrasound. And so I think that's something to remember first, also as for the test, but also in your clinical practice, is that, I have seen this. It's not common, but definitely it does happen. And the patient I had presented in a very similar way to this. And then, yeah, it is usually in older folks. So, I think, and obviously since it's a mass, we always think when we see a mass in an older person, we think, cancer, cancer, cancer as our first three things. So I think kind of my primary takeaway for this is remember this disease, watch for, especially on the test questions, kind of those priming things like like the fibrosis of the thyroid or of another organ. So, and then as mentioned, 60% have the IgG4, which is why it's IgG4 associated. And then this, we don't need to go through this because I already kind of chatted about that. And so, and I just mentioned that. So for any input from our rheumatologist, or
I know we don't have a lot of time, but just I see a lot of these patients, and some of them do not have IgG4 disease who have RPF. So just be aware of that. But it's fascinating. This whole disease entity has been recognized over the last several years. Autoimmune pancreatitis is a good one to remember. Mucklick's disease, which is enlargement of your carotids. Rydell's thyroiditis, which you've already talked about. Just little clues to the underlying cause of this patient. But again, not everybody has IgG4 disease who has retroperitoneal fibrosis.
I think for IgG4 specifically, it's also associated with eosinophilia to some extent and asthma. So they have this atopy-like feature that is interesting. When you're putting together a story for a differential, something to keep in mind about eosinophilia as well, and asthma, of course, the enlarging organ involvement, and multiple places where it can show up, as Gigi mentioned, the eyes, with proptosis, and then thyroid, salivary glands, of course, the around the kidneys.
Good, great, thank you. That's really good input. And anyone have any questions on this question before we move on to the next one? Okay, we'll move along. So another picture, some bull kelp, kind of just looks, yeah, it just always looks interesting. All right, can we have, or I'll read this one, just time to it. Which of the following, this is question number 3, which of the following tests is most likely to confirm the diagnosis? Option A, HLA-B27 haplotype testing, MRI of the right knee, serologic testing for Borrelia burgdorferi, or synovial fluid analysis for crystals. So, and then here is the question prompt. And then could someone read this for me?
Why don't you let me read it for you? So we're
Sure.
running out of time. 49-year-old man is evaluated for a 3-month history of right knee swelling without significant pain. He does a lot of physical activity as a park ranger in Michigan, but does not recall trauma. He likes to walk for exercise and does not have significant pain when he walks. He only has minimal discomfort in the knee and stiffness when he squats. He reports no swelling or pain in other joints, no fever, rash, or other symptoms. He takes no medications. On examination, his vital signs are normal. His right knee shows a large effusion without erythema, but with minimal warmth and tenderness. Full range of motion is noted, so it means he's probably had it for a while. The remainder of the musculoskeletal and physical examination is normal. Knee radiographs confirm a large knee effusion on the right, but no other abnormalities are seen.
Great, thanks. And then I can leave this up and we can vote now for this one. And just take your time. We'll give you a minute to submit your answers. Okay. Does anyone else need any more time? Or?
People are still voting. I'll give you another 2 seconds.
Awesome, thanks. I can't see who's voting or not.
No
So
problem. I have secret info. All right. Here are the results.
Great. Okay. So yeah, we had good. So with this one, we had kind of a smattering around. So that's good. We definitely had different people thinking different things for sure. So just kind of going, let's see, from the top. So for the first one, HLA-B27 haplotype testing. So I think I defer to our rheumatologist course, but when I see HLA-B27, I think spondyloarthropathies. And so then I think if maybe I have a high suspicion of a spondyloarthropathy or ankylosing spondylitis or such, I would maybe want to check that out. For this patient, with kind of an isolated, because basically what we have is just an isolated joint effusion, really with like not much pain. And that to me doesn't really fit one of those HLA-B27 diseases, or especially there's other better options. So, but that's definitely a good thought. So B, MRI of the right knee, definitely tempting for sure, because we always think more imaging can never hurt, right? Which in a sense, maybe, but I think in this case, we really get this is kind of one of the examples that the physical exam can really kind of show us more or less kind of what we need to know. The patient also already got knee radiographs already. If we were looking for signs of osteoarthritis, that would be the first go-to rather than an MRI. But even just on exam, even without the knee radiographs, that, we feel an effusion without a lot of surrounding inflammation and such. So in this case, actually, MRI, usually if we're worried about some issue with like the tendon or such, I get that some people may thought maybe had a ruptured tendon, or that maybe that would cause like the joint effusion or the swelling, but probably not in this case, especially without the minimal pain. For skipping down to D real quick, because C is the correct answer, but D, synovial fluid for crystal. So yeah, definitely common things being common, the crystal arthropathies, gout or pseudo gout is, definitely common things, can be a monoarticular, especially in the knee is possible.
But again, Scott, those would be very painful and would be self-limited. This is a chronic asymptomatic effusion.
Exactly. That's what I was going to say, is that those are often almost always painful. We've all seen people with gout and it's very painful. So that's why in this case it would not be that. And then finally the Borrelia burgdorferi, that is the correct answer. So this, we don't see a lot of Lyme disease here on this side. I trained in Vermont, so I saw a fair bit. Even it's like one of the highest states, or but even then, so part of it is a test, kind of, when they give you that he's a park ranger in Michigan. A little bit of this is easier on the test than maybe in real life. In real life, you kind of maybe have to suss this out a little bit more. Remember to think about that. But the question does kind of cue us for that. But yeah, meaning that this is one of the kind of presentations of Lyme. And remember that. We always remember the bullseye rash, but that is, which I've seen, but that is definitely not in all the cases. Maybe I think about a quarter of cases. So that is, so I'll just skip, sorry. Here we go. And that one was a bit harder, so not as many. Here, this is kind of what I was saying, and these are the other types. So I think with that, I'll just give my takeaway as, painless, maybe think a little more likely Lyme, or painful, think crystal arthropathies or such. So, but with that, I'll give our rheumatologist thoughts.
I just want to underline what you said, Scott, in terms of the takeaway points. I've made a diagnosis of this once in my career. It took me 3 visits to make the diagnosis. The patient was B27 positive as well. But I finally asked the right question. I said, when did this all start? He said, well, after I was camping in Connecticut. This is this, you will see this, but it's not very common. If you go back east to work, you'll see a lot more of it.
I think what I'll say is that, for me as a rheumatologist, tap, 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 like if you have a joint effusion, you don't know the answer, tap is fine. But I think that the idea was that they're asked specifically said for crystals. So I guess the implication was, are you thinking gout, which we weren't thinking gout. So I think that's what should, might have driven me to pick the Borrelia for, Lyme. But something to keep in mind is that I am a big fan of tapping in real life, if I can, but just, I think the wording was that look for synovial fluid for crystals, which is wrong, because we're not looking for crystals given gout. Yeah, so I think it's just a matter of test taking as well here.
Yeah, I agree. I think the question was not what's the next thing you would do, it's what would make the diagnosis. So you have to read that question carefully.
Exactly. No, I think that's a great point, because like you said, I definitely agree. Tap, 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 tap is important. So yeah, I think that is, the question is worded it very carefully. So any other questions on that before we move on? Okay. Well, then we'll move on to the next question. This is, again, all these pictures are from the San Juan Islands in the last few days, but this is a view of Mount Baker. So it was a nice clear day. So that was nice. Let me close this. Okay. So this, I can read this. This is our next question for which of the following is the most appropriate next step in management? A, begin high-dose glucocorticoids. B, begin plasma exchange. C, stop colchicine and clarithromycin. Or D, stop febuxostat. And then here is the question.
I can take this.
Oh, great, thank you.
A 78-year-old man is evaluated in the emergency department. 5 days ago, he was diagnosed with community-acquired pneumonia at an urgent care center for which he was prescribed clarithromycin. Yesterday, he developed generalized weakness and diarrhea. History is also significant for hypertension and gout. He has a history of allopurinol-induced drug rash. Current medications are lisinopril, colchicine, clarithromycin, and febuxostat. On physical examination, temperature is 98.4, blood pressure 104/60, pulse 112 per minute, and respiratory rate 18. Oxygen saturation 98% on room air. There is no rash, oropharynx is dry, The chest is clear. Tophi are noted at the olecranon processes. There are no swollen or tender joints. Neurologic exam is normal. Which of the following is the most appropriate next step? Begin high-dose steroids, begin plasma exchange, stop colchicine and clarithromycin, or stop febuxostat?
Okay, great, awesome. So we had most people are thinking C, some D, and some A, and no one for plasma exchange. So yeah, first I won't belabor it, but yeah, for plasma exchange, agree. For plasma exchange, we're usually thinking like TTP or some other disease where that would help. And yeah, it doesn't seem anything here would be something that plasma exchange could help. So for begin high dose glucocorticoids, yeah, that's always maybe on the rheumatology or autoimmune. We're always wondering if, hey, maybe could steroids help this? I think, oh, sorry, I just realized something. Sorry, I just realized you guys got the right answer anyway. I just realized I forgot to show you. They gave us some labs, which may have changed your thinking. But let me just throw this out there. You guys got the right answer, and I think the labs almost were safe. But just really quickly, the lab showed hemoglobin of 9, elevated creatinine kinase, elevated creatinine, no schistocytes on the blood smear. So sorry about that. I messed up on the question. I forgot this one had 2 parts, but still, yeah, given then, you know, it's not TTP because there aren't schistocytes on the blood smear. And also the patient doesn't have like altered mental status, which usually is there, but not always. And you definitely see TTP and it's an emergency. So we always, you know, kind of watch out for it. But so, and in that case, if you suspect TTP, the answer is plasma exchange, but that's not in this case. And then for high dose glucocorticoid, sorry, maybe some of you may have selected more of that if I would have correctly shown you the labs, but given that, you know, someone with this kind of pancytopenia or this anemia, sometimes we think of like Evans syndrome or an autoimmune hemolytic anemia or something, maybe you could be thinking, but most people correctly did not choose that. And then D, so I think almost everyone got that this seems kind of like a strange thing in that it's a medication interaction. And some people said febuxostat. That is, you know, a medication that I personally do not prescribe, you know, that often. And there is, you may be hearing or remembering bad things about it because it got a black box warning for, I believe, like cardiovascular kind of increased risk of cardiovascular death or symptoms. So that may be why people are tempted for febuxostat. But the correct answer is C, stop colchicine and clarithromycin. This is, you know, the patient, you know, is on colchicine, which some people are, especially if they have an allopurinol allergy or still have symptomatic gout and such. But so this is an interaction. Colchicine is inhibited by the CYP3A4, and clarithromycin is a CYP inhibitor. And in addition to that, I think there's also kind of another effect to it. So these, you know, it's been a while since I've even prescribed clarithromycin, but I think the point here I would say is that the test, colchicine is a common med, and the test does definitely test uncommon medication adverse effects of even, you know, fairly common medicines. So with that, sorry about the labs again that I messed that up, but you guys got that great. And then I'll skip over this. You guys can look at that later in the file. But yeah, from our
Yeah,
rheumatologist.
I've actually seen this happen before.
Hmm.
It's a very important issue. Using colchicine in people with renal insufficiency can do this, but also certain drugs like cyclosporin and tacrolimus. We actually wrote a paper on this one time.
Hmm.
So where you'll see this is in your renal transplant patients or your transplant patients who often get gout. And you have to be very careful with using colchicine in those patients. So if you're going to be a hospitalist, maybe an outpatient, you got to keep this interaction in mind. It's a P glycoprotein that's inhibited by clarithromycin, cyclosporin, tacrolimus that inhibits the trafficking of colchicine in and out of cells and makes it build up. And you get this neuromyopathy from colchicine excess. So yeah, be aware of that and just use colchicine very sparingly in some of those patients. I'll give Namrata the last word.
No, I think this is very, very important question. I feel I don't know what your boards are going to look like, but I feel something like this definitely will sneak in for interaction. And statins is another one to keep in mind because you know, given their comorbidities, these patients are on drugs like statins, and the interaction is something to keep in mind.
Thank you. Any other questions on that? Or I think maybe we can squeeze in one more question, maybe. So, okay. Then I think we'll keep going ahead. So we'll skip, that's me at a big tree. So I like big cedars. So, okay. Which of the following is the most appropriate next step in management? Oh, sorry, we're skipping this one. Sorry, this one is honestly kind of, yeah. Okay, this one's better. So which of the following is the most likely diagnosis? Disseminated intravascular coagulation, hemolytic uremic syndrome, scleroderma renal crisis, or TTP? And then here's the question. I'll read this just for time. 36-year-old woman is hospitalized for acute kidney injury and hypertension. She has an 18-month history of diffuse cutaneous systemic sclerosis. She was well and taking no medications prior to her hospitalization. On physical exam, temperature is normal, blood pressure 240 over 130, pulse 100, respiratory rate 18. Cardiac exam reveals a prominent S4. Pulmonary auscultation reveals bibasilar crackles. Cutaneous examination reveals sclerodactyly of both hands, as well as induration of the forearms and anterior chest. Hemoglobin is 8, and platelet count 90,000, creatinine 4.9, urinalysis a little bit of protein. Peripheral blood smear shows schistocytes and decreased platelets. And then, oh yeah, we have, whoops, let me go back to that. Okay, and then we can vote. Yeah, great. Okay, excellent. So I was going to say you are excellent residents and are very on top of it. I won't belabor this too much, but that is the correct answer. I think, given her history, I think the biggest thing for me about this that I have is really, think of your pre-test probability in a patient with 18-month diffuse cutaneous systemic sclerosis and they're coming in with hypertension and an AKI. That really the thing is to think of is the scleroderma renal crisis. Really quick to just go over just some of the other ones is someone chose hemolytic uremic syndrome, which is, and great, the other ones they threw in here, I think, because these are signs, you can actually get this from the scleroderma renal crisis. You can have the schistocytes, the decreased platelets, the anemia, and you can also have the prominent S4 and the bibasilar crackles from when your blood pressure is that high. It can cause kind of heart failure types. But so going from what I'm saying with that is that they will kind of give you things to maybe try to throw you off, but I'm glad that most of you were not thrown off by this and got this scleroderma renal crisis. So mainly it's remembering what that is. So, and with that, I'll let the rheumatologist talk more.
I'm gonna let Namrata make the first comment this time. I didn't hog in the first comment.
No, that's I think this is impressive work. I mean, nobody got distracted or confused, so that was pretty awesome. I think this is a diagnosis that has gone a lot into non-existent just because ACE inhibitors are very, very good treatments, and most of our scleroderma patients have hypertension. So we put them on ACE inhibitors, and I don't think I've seen a new one. I mean, I have patients with history of this happen back in the day, but not necessarily new onset scleroderma renal crisis anymore. And I think that's probably because we now intuitively for hypertension prefer ACE inhibitors in these patients than other antihypertensives. And you know, the mortality used to be like very, very high from this condition, so which we don't see anymore because we don't see the condition. But other than that, I think there's HUS caused by a prior history of dysentery, and you know, but then there are atypical HUS as well, which for this stem we don't need to go into, but something to keep in your mind. And again, DIC and TTP can present with the you know, hematologic presentation similarly, but I think given the scleroderma history, that's pretty good takeaway.
Yeah, actually, I'm on the MKSAP committee, and I think I actually wrote this question. Anyway, so a couple of points. I agree with what Namrata said. The other issue is this often happens after a course of steroids. So you've got to be very careful using steroids in patients with scleroderma. It often occurs early in the course of disease, and you can see it with limited scleroderma as well as diffuse cutaneous scleroderma. There is an antibody, the polymerase 3, that if it's present in the patient increases your risk of both skin involvement as well as renal involvement, just a little pearl. And then if you're a hospitalist, what you'd use for these patients, and I've seen several of these patients over the years, you'd use captopril, which is a short-acting ACE inhibitor. Then you would titrate that for the patient's blood pressure. The patient can have prolonged renal insufficiency after this, but so it can be, as Namrata pointed out, this used to be the major cause of death. And we now have a disease-modifying agent in the form of ACE inhibitors. And this test, as John pointed out, will be on your board exam. I can almost put it in writing that it'll be there. So
yeah,
you'll get this one.
Yeah, you'll get this question, and then sorry, I know because I'm out of time, but I'll just say really quickly, I did actually see this a few weeks ago on the wards, and I can't actually remember though if the patient was not taking their lisinopril. I think they were taking. I don't think there was an issue with that, but they still had came in with an episode, and we did use captopril, and she got really better really well. So just something to remember, because it's something that has high mortality if untreated and missed, and pretty low mortality if treated and caught. So, okay,
Scott,
well, yeah.
Scott, there's a question. What
yeah.
is the goal blood pressure for acute management? Like how fast and how low to drop? Do you want to tell us about that patient you saw?
Yes, no, for sure. So yeah, thank you. I think, yes. So the goal for acute blood pressure management, and you will get this like every other day as a hospitalist, how fast should you drop the blood pressure? And it actually is basically kind of disease independent, actually, almost with maybe one exception. But for that, and that would be like aortic dissection, is you want to just drop it as fast as possible. But with the exception of aortic dissection, it's actually pretty well that you want to drop the blood pressure by 25% in the first like 6 hours or so. And then you don't want to drop it too much after that. Then after 24 hours, you can drop it kind of lower to like a more normal level. The reason just for that is that, and there's been all these, there was things we do for no reason is using IV antihypertensives too much, because actually sometimes if we drop people's blood pressure too high, we call it relative hypotension, is that if your set blood pressure, if you're at a blood pressure that's really high for a bit, your brain kind of does these automatic responses to decrease the cerebral perfusion. And so if you drop it too low, the issues you can actually get stroke from cerebral hypoperfusion. You can get myocardial infarction from myocardial hypoperfusion, because the heart does a similar thing to a lesser extent. And you can get AKI from renal hyperperfusion, again, similar to a lesser extent. So sorry if that's too much blabbering, but I would say in general, unless if our rheumatologist had a different take, I would say dropping it by about 25%. So if we just in the first 6 hours, and then you can kind of return it to normal or drop it by half in the first. So I'd have to do my math on that, but you would still, maybe get them to 180 or so over 100 in the first 6 hours.
Okay, great. Well, we are just about out of time. We actually ended perfectly on time, which is rare for our MKSAP session. So thank you all for participating. And thank you to our experts as well for all your insight. We're going to go ahead and take, we can come back at 9:55, so just under 10 minutes if that's okay with everyone, so that we can stay on track, and then we will continue on with our morning. We actually have another room topic coming up next, so it'll be really exciting. All right, thanks everyone.